Great pleasure today to have Professor Ali Rezai from West Virginia, one of the most recognized neurosurgeons in the treatment of functional disorders. Thank you, Professor Rezai, to take our time with us. It's a great pleasure to you. We are now in the seventh section of the Al-Meftys series. No, seven section, yes. We have more than 5,000 participants and people that assist online or in YouTube later. This is a great success in the webinar for the neurosurgery. Today, Dr. Rezai is more than a neurosurgeon. Dr. Rezai is the man that taught something to our mentor, Professor Al-Meftys. Many years ago, Dr. Al-Meftys decided to learn DBS. And Dr. Al-Meftys went to Cleveland Clinic. Imagine the situation. And after that, he went back to Arkansas and tried to do a transpetrosal approach to DBS. And you see that was not working so well, Dr. Al-Meftys. He decided to stop his career in DBS placement. Here I have Professor Alexandre Francisco, is a great friend of us, a functional neurosurgeon from Brazil, that we introduce our guest, Dr. Ali Rezai. Thank you, Alessandro. Thank you, all the participants, Dr. José Osvaldo, Jean Oliveira, Professor Prinzo from Uruguay, Professor Moura from Ecuador, and all the people that will be watching online this time on the YouTube. Let's start again. Thank you.
Thank you. It's a pleasure to have you all here. Welcome to the Al-Meftys Neurosurgical series. Dr. Al-Meftys, good evening. It's a pleasure to see you online. And with no further ado, I will introduce to our guest. Is my good friend Ali Rezai. Ali is the John D. Rockefeller Chair in Neuroscience and also the Associate Dean and Vice President of Neuroscience at West Virginia University. Ali will talk to us, will speak about DBS and also very thoughtful insights about focused ultrasounds in the treatment of not only functional disorders, but tumors. Ali, welcome. It's a pleasure to have you here.
Thank you, Alex, and also greetings to all the esteemed colleagues from across the world, and also Professor Al-Meftys. It's a pleasure and honor to be asked to speak. And also we have many distinguished functional neurosurgeons also, so it's a great pleasure. So appreciate very much the invite. And I was going to break my presentation into two lectures. One, talk about a DBS update and where the field is right now and some of the innovations in the field that's going to define the, I would say, the next decade. And then I was going to talk about the work that's ongoing with another very innovative technology of focused ultrasound technology, which I think is going to significantly change the course of functional neurosurgery with its applications. Can you all hear me okay?
Perfect.
Yes? Okay.
Yes,
very well.
Very good. And just please interrupt any time for the presentation to ask questions and all that. It's very informal. So again, thank you very much. So I'll start first with the DBS lecture here and where we go. So I'll just go here. So the update here for my colleagues, many of you know DBS has now a 30-year safety track record, which is very important. And there's more than 200,000 patients in the world who have had deep brain stimulation implants. And it's Food and Drug Administration approved in the US and insurance reimbursed. And many companies are making DBS systems right now, Medtronic, Abbott, Boston Scientific, other companies in China and others. So a lot of activity, and it's really standard routine with many randomized trials, clinical trials that have shown proven safety and efficacy with movement disorders, essential tremor, Parkinson's, dystonia are the approved indications in the US, and epilepsy, as well as for obsessive compulsive disorder. So these are standard applications, and the results are very significant in terms of improvements. You can see with the patients really get significant improvements. For some reason, I'm not able to play the video. I don't know why on this, but we'll continue on. This is some of the publications that's shown from 1980, and you can see there's been an exponential increase in the number of publications with deep brain stimulation. And also looking at the various indications for Parkinson's to obesity to anorexia, Alzheimer's, tinnitus, and many others. There are emerging innovations for DBS. Imaging science, very important. So we're evolving beyond the standard approach of targeting with anterior commissure and posterior commissure based targeting to now having innovation and refinement that allows us to better identify. You can see here 1.5 Tesla imaging looking at globus pallidus, and you do a 3 Tesla imaging, you have a better definition of the structure, and with even higher resolution, you can have very nice structure, the various components of subthalamic nucleus and others that are targeting the brain. By 3 Tesla, really we can get nice quantification of the structure. There's other stereotactic approaches looking at, for example, targeting the ventral VIM nucleus directly by visualizing an MRI right now. And then some of the unique sequences like the QSM sequence for GPI, where you can see the subthalamic nucleus and globus pallidus, internus and externus very nicely using this technology. Parcellation is also evolving, where we can look at the thalamus and looking at individual nuclei that are parcellated with the new technology, and can help use that in targeting the different nuclei for the different applications: sensory nucleus for pain, motor nucleus for movement disorders, Tourette's, intralaminar nuclei, and then also the anterior thalamic nuclei for epilepsy. Tractography is also proving to be very effective in using tractography, so we can look at the fiber tracts, so we can see where the pyramidal tracts are, where the sensory nucleus is, where the ruberothalamic tracts are, so we can see where all these tracts are in addition to the nuclei, in addition to the imaging, to help us target better. And again, tractography is really helping us refine our targeting, whether it's for lesioning or whether it's DBS, and is being used for our targeting approaches. Okay, continuing on. This is an example of using tractography, where you can see is an axial section of the brain, anterior commissure, posterior commissure. And you can see tractography localize the medial lemniscus, the pyramidal tracts in the lateral thalamus. And you can see this is an example of a thalamotomy lesion that we did for HIFU, focused ultrasound. I'll talk about that. But tractography, you can look at the target with the cerebellothalamic tract coming from the bottom of the VIM, and localize the tracts in the pyramidal tracts, as well as the some of the sensory tracts, so you can stay away from those. There's probabilistic stimulation maps that are coming that looks at outcomes clinically that are reinserted back into your targeting maps. So as you're targeting the brain, you're identifying the sweet spot across a large group of individuals. Here's some examples of papers where you can see targeting based on outcomes. And these are going to be evolution of technology in the future. Functional MRI, great work coming out of Toronto, looking at now we can use functional MRI and be able to use that for patients to further come up with an objective, more biomarker for clinical response by looking at patterns of changes in the signals in the brain with the functional MRI and DBS on or off. So those are elements that are evolving. Other innovations, awake. Many centers do awake versus sleep now. So sleep DBS is now standard, and many do no microelectrode recordings. We still do it. I still do it. I do it awake, but many centers don't do it. And many studies that are showing that the benefits are similar between awake and sleep DBS, no MER, and just anatomical targeting. And in my opinion, it's okay 90% of times, but 10% of the time is not optimal. That's just my belief, but many studies show the same equivalency. And this is a good study coming out of Toronto that looked at comparing 80% of trajectories. There was a good correspondence between image-based anatomical targeting and microelectrode recording. And then, but 20% of them, the targeting was suboptimal. So I think that makes sense. Also, I would say 10% to 20% of times you may have suboptimal targeting if you're just doing it based on anatomy alone, because of variation and other individual changes in patients with their anatomy and the optimization. That's why we think that microelectrode recording or macro stimulation and getting the feedback is very important. other emerging innovations, we talk about early DBS surgery. It's a great paper that was published in 2020. And this is from the Vanderbilt group and Pete Conrad, who's here with us at Rockefeller Neuroscience Institute now, looking at individuals that were 50 to 75 years old, and they had medication response, had to be stable, and they underwent DBS versus optimal drug therapy in 28 subjects. And very important study. And they showed that there was worsening of overall motor symptoms was 2.3 times more likely in those getting the medications optimized drug therapy versus DBS in this early stage cohort. And then the resting tremor was 5 times less likely in the DBS subjects, and dopamine requirements was 4 times higher. So this study is a very important study for long-term, and that shows that there's evidence for disease modification potential for DBS, the subthalamic nucleus, and argument for doing this early on in the disease process before you tried various medication. And I think it's a very important study. The Europeans had an early STIM study as well. Long-term outcomes of STN DBS, 15 years in this study was 17 years looking at it. And they showed that dyskinesia time in the 17-year follow-up was 75% reduced in Parkinson's patients, and the time off space was reduced by 58%, and the drugs were reduced by 50%. So 15, 17-year outcomes, robust, early DBS and PD, robust outcomes. And then continuing on, another good study looking at, in 2020, looking at DBS freezing of gait. And really in this was part of a European early STIM trial. And they looked at those Parkinson's patients had early motor complications, and half the patients in both the treatment and non-treatment group had freezing of gait at baseline. And at 24 months, the stimulation group had a 34% reduction. And this was really a nice study that shows the axial signs and symptoms improve with stimulation with DBS compared to best medication management. Directional DBS electrodes. Again, this technology is out there right now, Abbott, Medtronic, and you can see instead of the standard cylinder that we've had for over 30 years, now you can directionally stimulate anterior, medial, lateral, and this provides a flexibility for targeting different sectors in the brain. And this is an important innovation. You can see some of the papers show, for example, in this axial section, when you have a regular standard DBS electrode, stimulates an all quadrant, but a directional electrode minimizes the current spread to the internal capsule, causing speech or contraction. So this, I think, is an important evolution for the future that makes it a better utility for the future. Lots of studies are coming out, but this is one of the better studies that showed the therapeutic window, the window between the benefits and the side effects was improved in those undergoing directional DBS. So this technology is going to be good for the future. Sensing, very important, like in epilepsy, you can do sensing. The same thing is now with DBS for movement disorders and other conditions. We can look at local field potentials, and these are extracellular signals, and you can record them now with this new FDA-approved system that we have, the Medtronic Percept system, and you can look at the different frequency bands in the brain, in the subthalamic nucleus, in the globus pallidus, in different thalamic nuclei. You can isolate delta, theta, alpha, beta, and gamma bands and observe them chronically in the context of the disease, improvement of symptoms or worsening of symptoms. And you can see here where you can record the amplitude and the frequency domains, and you can look at to see if there's beta and gamma changes. And in Parkinson's, there seems to be a very importance of beta and gamma frequencies in terms of worsening clinical state correlated with beta and improvements correlated with gamma frequencies in the brain. Very important physiological feedback that's showing, and their studies are coming out where now this is being used routinely for feedback. And you can see in this another good study that shows improvements with adaptive DBS. This is with the feedback DBS based on local field potentials and improvements in the UPDR scores. But this will become more norm as we understand the pathophysiology of different conditions and beta frequencies in general being not as good as gamma frequencies for clinical improvements. Epilepsy, Many of you are epilepsy surgeons, and as you know, a third of the epilepsy is refractory to medication management, and resective surgery can be very effective, but there's a large number of refractory epilepsy patients who are not candidates, and these individuals, neuromodulation is a good option with VNS, and many of you do DBS with the responsive system with the anterior nucleus, and CMPF or intralaminar nuclei DBS. Again, many studies published looking at neurostimulation for DBS and others for epilepsy. And the anterior nucleus of thalamus, this was the initial cohort study that was published in epilepsia that looked at individuals with a multi-center double-blind randomized trial of looking at bilateral stimulation of the anterior nucleus of the thalamus, 110 subjects, and they showed 2 years with reductions of a percentage of median reduction of the seizure frequency. And this led to additional studies with the more longer term outcomes that was published at 5 years and progressive. And so very good results for this group of people with anterior thalamus DBS for epilepsy. And it was FDA approved in the US in 2018 as an adjunct treatment for focal partial onset epilepsy for 18 years and older, and those who have not controlled with at least 3 anti-seizure medications. Responsive stimulation, again, this is the NeuroPace device, FDA approved. Initial studies showed improvements, and longer term studies also with 9-year prospective efficacy studies published in Neurology last year also showed benefits in terms of improvements in the seizure frequencies and responder rates over time. So very effective technology for those with refractory epilepsy to help them function better. VNS, DBS, responsive stimulation. DBS for behavioral disorders, obsessive compulsive disorder, major depression, anxiety, addiction. Very complex disease. I've been involved in doing this for 20 years. Very challenging population, in my opinion. Despite very good science, but there's the psychosocial and dynamics, and this being not an objective symptom, a more subjective, makes it really difficult as compared to tremors that have objective improvements here. So can you all hear me okay still? Yes, very good. Okay, continuing on. So for this here, we can see this is one of the most common targets is the ventral capsule, ventral striatum target. And this target has impacts the networks involved in emotional regulation, inhibitory control, decision-making, behavioral self-regulation, and disinhibition, craving, and habit formation. Many technologies are stimulating the different nuclei, bed nuclei, striatum terminalis, ventral capsule, ventral striatum, nucleus accumbens. And looking at the target, the typical target, so you can see is the ventral limb of the anterior capsule, and then there's a shell and the core of the accumbens, and there's different specific anatomical subcomponents of that. Initial study was published in Bart Newton in Belgium with the OCD and DBS in 4 subjects in Lancet, and there's been more than 300 patients published plus with DBS in this target, looking at nucleus accumbens and VCVS DBS. And the global response rate for some of these studies was 60%. And the responders, if you have 25 to 35% improvement in Yale-Brown obsessive compulsive score. So the only thing that's FDA approved in the US as a part of a humanitarian device exemption is VCVS DBS for severe refractory obsessive compulsive disorder. The Europeans have also shown good results published in the New England Journal of Medicine with subthalamic nucleus stimulation and severe OCD in the non-motor parts, the behavioral parts of the STN, which has cognitive, behavioral, and also sensory motor parts. We target the sensory motor part more for movement disorders. This is in the non-sensory motor part. Treatment-resistant depression, subcallosal cingulate gyrus, I think is the most promising, and Helen Maybrigg and the colleagues have some great studies coming up. We looked at nucleus accumbens study and a long-term outcome that in a randomized sham control that we published that did not show benefit as compared to sham. There's studies of the medial forebrain bundle, but there's nothing that's FDA approved or approved with a long-term randomized control trial showing benefits. So this is still investigational right now. Other applications, we've tried ventral capsule, ventral stem DBS to improve the behavioral components of Alzheimer's, and also looking at people with severe traumatic brain injury with behavioral sequelae that were very significant, and which show some initial outcomes. But again, these are non-controlled studies. Addiction, big area, 50 plus years of research that shows accumbens, a very important target for addiction. And these are some of the initial studies looking at it for alcoholism, and the German group did a great job looking at long-term results for those that have severe addiction. They had some initial success, but the study had to be halted because they could not recruit enough subjects for the study. The Chinese group published in 2019, 8 patients of the nucleus accumbens DBS and anterior limb of the internal capsule, 3-year follow-up, and 5 of the 8 were abstinent. And this was a very nice study showing long-term outcome published in Brain Stimulation. We have a randomized trial ongoing right now with a National Institute on Drug Abuse, a study that was funded for our team. And this is the first patient that we published looking at DBS of the nucleus accumbens. Our first subject has had 600 plus total days of abstinence from severe opioid addiction with nucleus accumbens DBS. And this subject were end stage, had multiple relapses and multiple overdoses. So this is an ongoing study with the National Institute of Drug Abuse that we're doing at the Rockefeller Neuroscience Institute. And we looked at this initial subject. Again, we looked at metabolism with DBS, and there was significant change with therapeutic DBS and complete resolution of the use of drugs over 600 days now, and changes going on in the frontal lobe and other regions. And this is an ongoing study, so we looked forward to reporting the study. And we're also recording local field potentials in the nucleus accumbens related to behavioral changes or addiction, cravings, and other aspects of addiction here. DBS for Alzheimer's. And there's 3 different targets that we looked at over time. Andres Lozano and other teams did a phase 1 trial of the Fornix, 6 patients, and then 42 patients, phase 2, that showed it was safe and associated with the metabolic signal, but there was no difference in cognitive outcomes for participants. And now phase 3 trials undergoing, looking at earlier stage Alzheimer's patients. We published a 3-patient study in the Journal of Alzheimer's disease looking at VCVS DBS for the behavioral aspects of Alzheimer's, and all 3 patients had less performance decline, and 2 of them had a meaningful less decline, significant statistically. But again, it's a small sample of 3 individuals, non-randomized phase 1 study. The nucleus basalis of Maynard also has been looked at in 6 patients with mild to moderate AD, and they've showed 4 of the 6 patients were responders, but this was a non-controlled trial. So nucleus basalis, VCVS, and Fornix, which is the most active target for Alzheimer's. So I'll stop in this part and just want to answer any questions before I shift towards the focused ultrasound. Any questions that the group may have, please.
Ali, I think
Professor Al-Meftys, where are you?
He's learning about DBS.
Yeah, you know, Dr. Ghazai, I want to ask you something.
Yes, please.
About the DBS for Alzheimer's disease.
Yes.
And for epilepsy. In epilepsy, you have for temporal lobe epilepsy, especially, they have a standard treatment. You believe that DBS has a real role in these 2 pathologies, or a new thing that they are trying to do it?
I think DBS can help as an adjunct for epilepsy. I mean, there's the responsive stimulation, anterior nucleus stimulation. So I do think it can be effective, and the results of the trials are significant. And so I do think it definitely plays a role, as does lit therapy and as does surgical resection. So all of it, it depends on indication, but I think it definitely has a role here that can be played.
Dr. Al-Meftys?
Yeah. Can I share my screen for 1 second? Can
Go
I
ahead,
share
go
my
ahead.
screen?
Yeah, go ahead. Trouble ahead.
Do you see my screen?
Oh,
Yes.
yes, that's funny.
Yeah. Now, this is the front page of neurosurgery while back in one of the issue
Yes.
when Dr. Trinalis was the president of the CNS. And this great man, the late Dr. Nugent, he's my chairman in Morgantown, right where you're sitting right now, Wally. And the question is coming in, but I just want to make the connection. He did a lot of telemetry. I'm not in this picture, but I was with him on just about all the one he did when I was a resident. The question is, with the ablation, he knew precisely the target and he knew exactly what we destroying and what the results of that ablation. In stimulation, what is really the target? Especially with this Brazilian man coming out with those electrodes, which could stimulate from an inch almost apart. What's that new electrode? You're aware of it, right? Borba, what's the electrode you all having?
We use the Medtronic or Abbott or Boston electrode. I have heard of the Brazilian. Maybe Alex can talk about that. But
Alex and Jose Osvaldo, you know something about that? My electrode is for facial nerve, Dr. Al-Meftys, to avoid facial nerve palsy. Alexandre.
But anyhow, the main question here, the target.
Yes.
That's my question.
Yes.
What are you really? I know what you're aiming for, but what is really stimulating?
It's this exact same target, actually. With a DBS, we're just sending electrical signal that is causing an effective reversible lesion. But I would say lesioning is extremely effective. And it's the same target. DBS just provides more flexibility and in terms of being reversible, whereas a lesion is irreversible. So I think those who are experts at lesioning, like many of our colleagues in Brazil and South America and the rest of the world, the results are excellent. And I trained Ramon Tasker, as did Alex and others, and we learned lesioning very well in the mid 2000s. So in mid 90s, sorry. So I think same target, DBS just provides more flexibility and allows more people to be able to do it. But I would say lesioning is extremely effective in those who know how to make a lesion. And that's why, Sam, I want to talk about the next area, which I think is very interesting, is focused ultrasound, where I think is a big opportunity for lesioning. And I don't know if Reese still is on or not, but Reese is one of the pioneers in this and others. So focused ultrasound is extremely effective. So if I may get to the next part of the talk, where we can talk about focused ultrasound, which I think is going to transform.
And Dr. Kotzegrove with us, and there is, oh man, I'm so lucky, and we're all so fortunate because he is really in both the functional and the DBSs and the ultrasound. But as a skull-based surgeon, I got to ask you that question because it defies all the skull-based surgeon. There is a horrible, terrible facial pain called afferent facial pain. It's worse than anesthesia dolorosa even. We see it because anesthesia dolorosa is total loss of sensation. With this, you might still have some sensation. Horrible agonizing pain. We see it in some petroclival meningioma resection. and the treatment is defying. They did the medullary descending tract. I don't know if anybody's still doing that, but you at one time got into the cortical stimulation for this syndrome. Where we stand on that, just for this skull-based surgeon who's really kind of frustrated and defeated by this syndrome.
Yeah, no, this is an extremely difficult syndrome, and I love to hear from Reese and others experts, but we've tried motor cortex stimulation for this and DBS. Very difficult. I would say we've done 30 plus motor cortexes for this in my experience when I was at Cleveland Clinic and after. The results, I would say a 30 to 40% get some pain control, but it's extraordinarily difficult to deal with. I don't know, Reese, what are your thoughts, or Alex or others?
I don't know of any good treatment for it.
Yeah, it's unfortunate. Yeah. And so we tried motor cortex and those that have some sensation still, we don't have, if they don't have anesthesia dolorosa, we also do some thalamic stim, but I would say maybe a third of them get benefit. It's a very tough condition, unfortunately. I wish there was a better way.
I have a very small experience here, Ali, in Brazil with DBS or any kind of stimulation for the afferentation facial pain. But we did 3 cases in last year where we did PVG stimulation and also anterior cingulate cortex stimulation. And the results, it's a very small series, so it's a personal impression. They are not controlled studies. But I think there's some potential here when you think about treating pain itself. I mean, the proprioceptive, I mean, not the proprioceptive, but the epicritical sensation of pain. But when we turned on the anterior cingulate cortex lead, some of the patients, they start to refer that the pain is still there, but they don't bother them anymore. And it's very awkward to describe these feelings. But this is, as I said, I only have 3 patients. And so far, the experience has been very interesting. And all the 3 patients are satisfied with the short follow-up of these cases. But as we know, some of these patients along the run, they lose the effect of controlling pain. So it's still an ongoing observation.
Yes. Yep. Very difficult condition. Yes.
I think that Professor Osama is once again right. You have a real functional solidarity between all neurons. Afference and efference is multifactorial. Congratulations, Professor Ali Rezai, for the excellent review of current therapeutic options using DBS. I know that you are also a specialist in SCS. I ask you why SCS systems are always ahead of DBS.
It's a great question. It's all pure money because there's so many more of them. So the companies have much more potential to innovate. So there's 5 times more SCSs implanted than DBSs. So unfortunately, I think a lot of pain doctors and others do it. And it's just, it's a bigger market for competition. So that's why there's more innovation. But I like DBS now. I think there's good innovation with the directional electrodes, with the recording devices. So really nice technology is coming out. And with some of these advanced imaging, tractography and others, I think we can really make an impact. But I think, unfortunately, it's purely a result of more numbers and hence more need for innovation for competition.
To assess multiple targets, we had used SCS materials, which all of it, us to duplicate sinus with the generator and SCS connection. We were able to duplicate each 8-pole channel to 2 4-pole each DBS. So we were able with this to use relatively low frequency subprogram to stimulate, and several same programs, subprograms to inhibit. So in the same generator, do you think about this when we have not different frequency for inhibit and stimulate?
I think it's a great question that needs to be studied. I mean, the issue of frequency is very important, and I think that we have just traditionally used the frequency that's worked, and we've stuck to it. But I agree with you, that needs to really be studied more carefully, and the frequency, and then even changing some of the other parameters. And in spinal cord stimulation, ECAPs are used routinely now, and these are evoked action potentials that are used to give feedback stimulation with outstanding results from randomized trials. So I think there's a lot more science that needs to be done in this field.
Okay.
Indeed.
Thank you.
I think you should move along.
Yes, if I may talk about, so this is an area that Reese Cosgrove is the master of. This is the lesioning. So I remember I was in Canada. You came over, Ron Tasker, it was 96. You came over for a visit, and we're talking lesioning in the OR in Canada. So, or 97, rather, I can't remember. But Reese is a master in focused ultrasound. So my hat's off to him, and I went and watched him as well. So Reese, you should be giving this lecture. But
Ali, he's a master of everything. You would not
yes, he
believe
is.
how great and knowledgeable and experienced and
He
thoughtful
is.
in everything
He
Reese is. And this, I agree with you. He's master of the master.
He is, and a class act, and a gentleman scholar. So, and you have a great department with Nino and all that. So phenomenal department. So if I may, and Reese, maybe give some comments. This also, if I may, this is the summary about the some of the thoughts about the work with focused ultrasound. I'll talk about some of the Alzheimer's work we've done as well. But if I may here, sorry, this is HIFUS. Okay, so I'm going to talk about this, and please interrupt me anytime. But basically, tremendous evolution going on in MR guided ultrasound when MR was coupled with ultrasound really in the 90s. That really led to a very significant evolution. A lot of work done by Kullervo Heinen, and also Nate McDonald, who works with Reese. They were the pioneers in getting this really out there. You can see the dramatic increase in number of publications, Alzheimer's, looking at thalamic areas. I think this is a very important technology for the future, in my opinion. There are many preclinical systems that are custom built, and the clinical systems, many investigational devices, but the only one that's FDA approved in the US is for Insightec systems. I'm going to talk about that. This was approved in 2016 in the US for the treatment of tremor, and I think, in my opinion, this is one of the most elegant ways of doing lesioning without actually doing surgery in the brain. And there's no incision or skull opening, outpatient procedure. They go home within 2-3 hours, same day. And you do anatomical targeting just like you do for DBS or radiofrequency or other technologies like Dr. Nugent was doing. Same anatomical targeting, more sophisticated obviously, but focal and precise treatment, 1 millimeter. And the key is real-time feedback, MR thermometry, MRI target evaluation, and clinical assessments live on the MR table. So the MRI is no longer a diagnostic tool in neurosurgery. It's now a therapeutic tool as well, coupled with ultrasound. And I think this is going to transform the way we do neurosurgery next decade. 3,000 patients treated so far. And the application is new opportunities, lesioning. It's approved for Parkinson's and essential tremor in the US. Clinical trials are underway for Parkinson's, dystonia, epilepsy, chronic pain, OCD, and depression. Blood-brain barrier opening. We've done a trial now, 18 patients as part of our controlled trial that was underway. Parkinson's and targeted drug delivery, and then neuromodulation, where it's a low intensity for movement disorders and TBI addiction, not making a lesion or opening the blood-brain barrier. The most common approach is called HIFU, high intensity focused ultrasound, using a 650 kilohertz high intensity system that generates a focal ablation heat in the tissue, just like a radio frequency does. And that's the most common application. And what happens is you target, just like you do anatomically in the thalamus, MR guide targeting, you deliver ultrasound, 1,000 plus ultrasound waves, get to a pinpoint in the skull, real-time MR thermometry, you see it. So you do a test lesion, and if it looks good with no side effects and improvements, then you do a permanent lesion, and you can watch your lesion take effect. It's 2 hours, and the patient goes home. So they sit in the MRI, a helmet comes over their head, stereotactic frame, and you target it, and then you use 1,000 ultrasound waves being directed through the scalp to the skull to a pinpoint area, and you do a test lesion. If it's good, you can make a permanent lesion, or you can move it electronically and steer the ultrasound waves. Here's an example of one of our patients before the procedure. It's severe tremor, trying to write his name.
Try to do it with this right hand only. And if I try to write my name, steady in it a little bit, you can.
So that's writing his name or drawing circle. You can see here, circles, straight line here. And that's immediately after the procedure.
I have an idea.
The effects are immediate on the table.
I'm still afraid I'm gonna drop it. You got it. I've got it. Really
and him writing his name, and you can see the lesion right there with the central necrosis right there. And standard routine procedure. The innovations have been coupling this with water coupling to cool the head, because the energy going to the skull increases the temperature. Using phase correction to be able to get the point, the ultrasound beams to the target, and efficiency in delivery of the energy and thermal sensing. So you put the stereotactic head frame on, you do anatomical targeting, 6 to 7 minutes in front of PC, the same thing, the Guillaume method or any method you like. We use 11 millimeters lateral to the wall of the third ventricle, and we go 1 millimeter above the ACPC line or a little higher, as opposed to DBS where we go straight to the ACPC line. You shave the head, and it's a wake procedure. You do a test lesion if it looks good on thermometry, and you can see here, you can make a permanent lesion. You can also modify the location by looking at axial, sagittal, and coronal shifts in the temperature to get a more precise lesioning. Once you're satisfied, you make a permanent lesion, 50 degrees plus, and you can see here the effects are immediate. This is before the procedure here, and you can see the effects right after the procedure. I call it surgery, but it's not surgery. The tremor stops. You can see lesions right there in 2 different subjects. Randomized controlled trial published by Elias, UVA, and other groups, and Reese Cosgrove and others, shown, and Jianmu Chang from Korea, showed sham versus phosphathylamotomies, statistically significant benefits at 12 months. And then looking at longer term 4-year outcomes also, the results were very good for 4-year outcomes with no significant adverse effects as the experience became better. Adverse effects, this is a study that we published as a collaborative group in Movement in 2018, and we looked at 186 patients, and there was a 1.6% rate of severe thalamus-related adverse effects, and a lot of them were related to having balance, and that was initially we're targeting deeper, and so we're getting the current going down, the lesion going down below, and causing some sensory loss or ataxia. Now we target a little higher, especially with those that may be older, have some ataxic symptoms. And we also do tractography, and we go 4 millimeters, at least medial to the edge of the corticospinal tract. Our experiences is from our group when I was at Ohio State, and now here at West Virginia University, 50 plus we've done. Outcomes are 80% tremor control, complications, mostly mild and resolved within 30 days, ataxia, sensory numbness, but we've had 4% gait imbalanced unsteadiness, and 5% sensory complications that are permanent, much better as we learn more and the experience improved over time. It's also FDA approved for Parkinson's tremor, and this is the study, randomized controlled trial, showed improvement. And it's also going outside of tremor. Thalamotomy is done with focused ultrasound. You can see GPI for motor symptoms outside of tremor. Very nice improvements in UPDRS in the study done by Howard Eisenberg and colleagues at University of Maryland, UVA. And again, the randomized controlled trial for subthalamotomies. So any target that's DBS can be done with focused ultrasound elegantly without cutting the skin, and patients go home within 2 hours, same day procedure. This is the Obeso group doing the randomized controlled trial of subthalamotomy, and very good results, looking at 19.9 at baseline to 9.9. So subthalamotomy has also been done with the decent outcomes. And central lateral thalamotomy is done by Professor Jean Minot in Switzerland. Nice results. And this is for those that had severe chronic neuropathic pain with excellent results using focused ultrasound. And continuing on here, capsulotomy, the groups looking at OCD, again, the target is different than the DBS target. Is a lesioning target, 7 to 9 anterior to AC and 10 to 12 from the midline, and create and make a 5 to 10 millimeter elliptical lesion. Jinwoo Chang, Korea, done excellent work. And again, I think this is really highly interesting, where they see results 2-year follow-up for severe OCD with HIFU bilateral capsulotomy. They showed 54% were responders at 2 years. And 63% had Hamilton depression responders and Hamilton anxiety. So great study. You can see a double shot capsulotomy like it's done with Gamma Knife. And they reported a very nice adverse event profile. So great study. The Toronto group, the Sunnybrook is also looking at this, so it's interesting. Let me talk in the last few minutes about an area that I'm very enthusiastic about: blood-brain barrier opening, Alzheimer's, glioblastoma, Parkinson's, and other neurodegenerative conditions. This is using a different system, lower intensity, 220 kilohertz. And it's about 1% of the energy delivery we do for lesioning of the brain. And you have to couple this to microbubbles. So BBB, as you all neurosurgeons know, is a blood-brain barrier. You have the astrocytes, you have the pericytes, and you have the endothelial cells, and these tight junctions here that are there that form a diffusion barrier. Very important. And the blood-brain barrier has been a bottleneck in drug delivery. More than 98% of small molecule drugs do not cross the blood-brain barrier, and virtually 100% of large drugs do not cross the blood-brain barrier, and less than 1% of drug companies have a BBB targeting program. Just for comparison purposes, glucose size is 180 Daltons, and basically a BBB does not allow anything larger than 500 Daltons to cross. Many of these CNS drugs are 357 is the average size of a CNS drug, hence why it crosses. But anything more than 500 Dalton has great difficulty crossing. Peptides are 3,000 Daltons, siRNAs 13,000, antibodies 150 kilodaltons, viruses are 2,000. And you can see gadolinium is about 1,000. That's why it doesn't cross the blood-brain barrier. So this is an important problem in neurosurgery. We've done interstitial waivers, convection-enhanced delivery, catheters in the brain, but they're invasive, have adverse effects, and the limited resolution. That's where I think BBB opening comes in. And you can see here's an example of what happens BBB opening.
Deep inside the brain is a shield that protects against invaders. It's called the blood-brain barrier. It allows nutrients to reach brain cells from the bloodstream while filtering out germs and other harmful substances. But there's a downside. Drugs needed to treat brain diseases too often can't get through either. The blood-brain barrier is made up of cells that line most of the brain's smallest blood vessels. Those endothelial cells are tightly packed together, so only small molecules slip by. Many drugs for cancer, Alzheimer's, and other brain diseases are too big to easily pass through. But what if scientists could make the blood-brain barrier temporarily leak in just the right spot in hopes of one day helping those medicines sneak inside? To try, they inject microscopic bubbles into the bloodstream. MRI scans pinpoint the desired brain location. Then researchers beam what's called focused ultrasound right at that spot. The ultrasound waves make the microbubbles vibrate, creating a temporary opening in the blood-brain barrier. An experiment with a handful of Alzheimer's patients shows the barrier opened, let some harmless dye seep in, and then sealed back up. Similar small safety tests are getting underway with brain tumor patients and people with Lou Gehrig's disease.
So continuing on here, this system has about 1% of the power delivery for lesioning. So it's very safe, and you don't need to shave the head also. And in 6 months, there will be a frameless system. So now the MRI by next year with this technology, you can just go into the MRI and get treatments without shaving the hair, without stereotactic frame. And you can see here what happens here. You have this endothelial cells in when you inject microscopic bubbles that you do for heart imaging, for example, it goes in the brain vessels, and that local area, the BBB opens up. So many studies done preclinical, no time, but based on many studies. And in an Alzheimer's animal models, they showed blood-brain barrier open, and you have increased dendritic numbers, increased neurogenesis, and they're showing increased autophagy occurring as well. They see when the blood-brain barrier opens, antibodies, IgG and IgM get in the brain, focal in the area the blood-brain barrier is opened. And again, they're showing reduction in plaques and improved memory. But these are animal models. So let's look at humans now. And in humans, if you look at it, Alzheimer's is a big problem, and there's no effective treatment worldwide, a big problem. Many studies done, but mostly look at 65% of the trials are looking at anti-amyloid or anti-tau. There's disease modifying is the most important approach, but there's also symptom modifying, but there's no cure, and 99.6% failure rates. This is a chart that shows phase 1, phase 2, and phase 3 studies. And you can see adenosine. This has been a lot of controversy. It was recently approved by the FDA for use in people with Alzheimer's with intravenous infusion once a month for 12 to 18 months. Eli Lilly is a drug that was published also in the New England Journal of Medicine. Very interesting era right now for the treatment of Alzheimer's. So human studies, the Near Lipsman and the Colervo, they're one of the pioneers in this, looked at the Alzheimer's feasibility. In Nature is published where they opened the blood-brain barrier and it closed 24 hours later. It was a 5-patient safety study. Then we started the study trial looking at a phase 2 study by opening the blood-brain barrier in the hippocampus, frontal parietal lobes areas positive for amyloid beta. And this is 18 patients enrolled. We've enrolled 9 here so far at the Rockefeller Neuroscience Institute in West Virginia, Ohio State 6 subjects, and Cornell 3 subjects. And the goal was to safe opening the BBB in frontal, parietal, and hippocampus, and also look at PET scans to see how much of the beta amyloid is reduced and evaluate reduction in clinical deterioration. We gave 3 treatments for each subject, each 2 weeks apart. Again, initially we shaved the hair. Now the last 2 subjects, we've done no shaving. We still require a stereotactic head frame, and the hair is good up to 10 centimeters. And we target the areas, for example, hippocampus, frontal lobes, and parietals, and precuneus and posterior cingulate parietal areas high with a plaque load. And we use a 220 kilohertz system and inject microbubbles. And here's the results. We did the first patient in the US in 2018. And you can see we targeted the hippocampus, and we saw we targeted the hippocampus positive beta amyloid and opened the blood-brain barrier. Here's an example of the ultrasound beams going to the hippocampus in this case and targeting it while there's the microbubbles going into the brain. And this is the results. And baseline gadolinium contrast within minutes after the opening, strong contrast enhancement hippocampus and entorhinal cortex. 24 hours later, contrast is gone. BBB is closed. And subject 2, subject 3, this is another subject. You can see closed, open, closed. And again, baseline, immediate post-sonication. Within minutes, the entire hippocampus lights up here that we targeted. 24 hours later, the BBB is closed, no gadolinium gets in. And here's another subject. And we published this in PNAS last year, looking at our initial cohort hippocampus, where we saw 95% of the area that we targeted, the BBB opened. And we targeted 30% of orbital hippocampus. Based on that safety, FDA said, go ahead and open different parts of the brain. So now we're doing frontal and parietal and precuneus and other areas. And we're opening 30 cc's of the brain volume on demand. Hippocampus, frontal lobes, and the parietal lobes, looking at the areas for spatial orientation, precuneus, posterior cingulate frontal lobes. And our last subject was 30 cc's we did last week. And we're open on average 75% of the area that we target of the 30 cc's. You can open the blood-brain barrier immediately. Here's our initial cohort. And you can look at the first 10 subjects with 32-month outcomes now, minimum 3 months, and no neurological worsening. And when we compare it to an ADNI comparator cohort, we're seeing trends where the rate of progression is not as severe as the ADNI with the p-value, but numbers are very small. I want to be cautious, but it seems that the rate of progression is stable. We need more studies, more data for this. We looked at PET scans, and we saw within 90 days, we saw average of 3.4% reduction in beta amyloid, and it's gone to 10% reduction at 1 year now. That's another paper that is being submitted for 1 year PET scan. What's the mechanism? We published a study in Radiology this year where we showed activation of the lymphatics in the brain in Alzheimer's disease with BBB opening. And the mechanisms of this are interesting, is multifactorial. We think that this local inflammation, a local ARIA that's controlled is being done, and neutrophil microglia recruitment, intravascular proteins get access to the brain, albumin goes in, binds to the beta amyloid or tau, and it is enhanced removal, clearance of pathological proteins. And some groups are showing that the ultrasound breaks down these larger plaques into smaller, more soluble proteins that can come out of the through the lymphatics. So we've done safety now. Up to 30 cc's can be open. No hemorrhage, 33-month follow-up, and no deterioration in neurological cognitive function as compared to ADNI cohort, and reduction in pain signals. Caution, 10 subjects. We have 8 more, but we need more follow-up. This is a trial ourselves, Mike Kaplan, his group at Cornell, Zion Zibli in Sheba, and also work with their Vanderbilt University, Dan Klassen, doing the PET analysis. And we're doing centiloid analysis now that shows more than 10% reduction in beta amyloid, but that's an ongoing study. Another study was published, very interesting. The Obesos group opened the blood-brain barrier, published in Nature just in the last couple of months. And they showed in Parkinson's patients, they opened the blood-brain barrier for the cognitive aspects of Parkinson's. Again, keep in mind, Parkinson's, you have alpha-synuclein, and you also have beta amyloid Parkinson's. And they showed BBB open parietal occipital areas, and they showed mild cognitive improvement. Very interesting, but this opens up the possibilities going in other neurodegenerative conditions. So they suggest BBB opening and drug delivery, which is the next steps. So this is the aducanumab, and this was FDA approved. And this is the study that's caused a lot of controversy. You can see the baseline, because it's the first time the FDA has approved something based on a biomarker in the brain versus a clinical signal. Very interesting. And you can see placebo, low dose and high dose PET, and there was a very significant reduction in the beta amyloid in the brain. So they approved it based on that. And now another study that was recently published by the Australian group, where they now combined aducanumab in animal models with opening, and they saw a 5-fold increase in the brain of the mice. And they are saying now that, hello? Oh, can I continue?
Yes, sure.
Yeah, please go ahead.
Yeah, sorry. I thought it was a question. So the ultrasound should be considered as a treatment option for Alzheimer's disease, and combining with the drug to increase brain levels of antibody here. Very interesting results. These were all 2021 publications, recent. So glioblastoma, a lot of interest in there. Herceptin, FUS has been shown to increase delivery in the mouse brains of antibodies here. Methotrexate increased. Temozolomide increases. And Avastin has been increased with publications with drug delivery in the brain of animals. This is a great study done by Jinwoo Chang, looking at 6 patients with glioblastoma and temozolomide, and they showed that the blood-brain barrier disruption opening was observed in 134 targets for glioblastoma and 92%, and they showed the results of this, and they showed survival, a very small number, caution, 6 patients, but they showed a survival of 100% in 1 year, and 2 patients showed a recurrence of tumor at 11 and 16 months. GBM, we all been there, many things exciting, but it all failed. So I want to be very cautious, but it's interesting to combine with 6 cycles of temozolomide. And this led to this current study that we're part of it with looking at safety and feasibility now with University of Maryland, Brigham Women's, and Reese, I think you and Golby's involved in this. We're doing it, and UVA. And the target region is within 3 centimeter margin around the tumor. Here's our second subject. You can see BBB opening here, and we're giving it with 6 cycles of temozolomide. This is our first patient that we did a few months ago for this trial. Carboplatin animal models, very interesting, that showed carboplatin also with ultrasound, you see enhanced survival animal models, and that led to the new study of recurrent GBM carboplatin study. Cleveland Clinic, University of Maryland, Stanford, and NYU, and Toronto, and Israel and Korea are doing this with BB disruption for recurrent glioblastoma with the clinical trial for recurrent GBM. The French group has a different device, not FDA approved. This is the Carthera, is a Burhole device, and a great study, elegant study in 21 GBM patients. They showed that the dose with BBB opening had a progression-free survival of 4.11 months and median of 12.94 months as compared to those that did not get BBB opening. So interesting results for this group. Another shifting over, this is my last few slides. This is a study published showing genes, the AAV gene against the alpha-synuclein and a short hair RNA segment. They showed that 40 to 60% reduction in alpha-synuclein 1 month post-FUS combined with gene therapy. And it was localized to the sonicated region. It gets, when the BBB opens, you deliver the payload and it stays in there. Mike Caplet showed a very nice study in animals in neurosurgery published with a targeted AAV gene expression vector into striatal neurons with a GFP transgene expression stable over an extended period of times, up to 6 months, and ongoing stable expression for 16 months. Very interesting. The genes are delivered without cutting the skin with focused ultrasound and transvenous delivery. Stem cells, great studies. Again, Kalervo, others looked at, and Jinwoo, that with focused ultrasound animal models, you can deliver mesenchymal stem cells to the brain by 2-folds. And I think Jinwoo is doing humans as well. So FUS is a very important technology. Not a surgical procedure, does not require radiation, couples live imaging with targeted focused ultrasound. And my last 2 slides, MRI, I think, is now a treatment tool as well as a diagnostic tool. It's FDA approved for the treatment of Parkinson's, essential tremor, consistently done. There's also, it's for unilateral. We're part of a study looking at bilateral tremors, similar results, very good results so far, but it's not approved for bilateral. And clinical trials still for Parkinson's, non-tremor, dystonia, epilepsy, chronic pain, OCD, and depression. Alzheimer's clinical trial, Parkinson's clinical trials, and brain tumors. And neuromodulation is no BBB. And we have 2 patients we've done for drug addiction, where we delivered the ultrasound neuromodulation dose to reduce the cravings by targeting the accumbens, and TBI and movement disorders are being studied. So, last slide. I believe there's a tremendous opportunity for neurosurgeons now, where now you can do studies where you can deliver focal controlled and on-demand delivery of medications, growth factors, enzyme replacement, antibodies, GMO stem cells, into the brain, and that dramatically opens opportunity for neurosurgeons. And that's my last slide. I'll stop, but want to give you an overview of ultrasound, which I think is a very innovative technology. And maybe Reese can provide comments. You're a master in this as well. But I think this is very exciting, in my opinion, for the future.
Thank you, Professor Rezai. Thank you very, very much for very exciting in the future of many, many neurosurgery and neurological disease. And I want to say one thing. Last year in the pandemic, I did 4 months of webinars every day. The Brazilian Society was online. I was at home today. And came a guy that talked spinal cord stimulation. Man, I was 4 months sitting on the table, and my back was like this. Okay. When I finished his presentation, spinal cord stimulation, I said, oh, maybe I need spinal cord stimulation. God was good to everything. Maybe this focus ultrasound. Today you saw so many indications, so many things. Just between you and me, what do you think is real, the benefit in all these trials, that you really feel the focus ultrasound will be will be worthful? See, in whole Latin America, we have just one focus ultrasound in Santiago, Chile. Now they're fighting there that it was so expensive to buy the machine that they cannot pay. In Latin America, every week or every month, somebody comes to us to tell Dr. Prince is moving their head to try to sell the focus ultrasound. I'm in a poor country. Our main audience is from Latin America and from Middle East. The people from Egypt, from Kuwait, from Saudi Arabia, the main audience of our webinar. Why should I buy the focus ultrasound and spend a lot of money for this? Which one will be the disease that will really change the history? Your feeling, not, I know you have a lot of trials today, we are using to everything, but what do you think that will be the best? What's your feeling?
Great question. And also, it would be great to get Professor Cosgrove's master opinion on this. But from my perspective, I've been involved in focus ultrasound 5 years. And I agree with you. The technology is very expensive. And and there's also a lot of custom systems. You don't have to have the Insightic device that's $1 million, very expensive. But I think this technology will get cheaper and more available, and there'll be more companies coming into this. In my opinion, I was fortunate to learn lesioning from Ron Tasker when I was in Toronto, and lesioning is very effective. So people around the world doing lesioning, excellent results, no question. But I think focus ultrasound makes it without the need for surgery. It's done by neurosurgeons still, but the MRI becomes a tool. Your patient goes home in 2 hours for tremor, and it is very effective. Patients love it. So I think for lesioning, it will play a stronger role because it's linked to an MRI. But you're right, the cost has to come down, and many centers are using maybe their own custom-built systems. But I can only comment on the FDA-approved device. That's the one we're using here. But in my opinion, the biggest potential is how it's going to change neurosurgery potentially is blood-brain barrier disruption, where we can deliver gene therapy, medications, things that we were not able to do before non-invasively. And like I said, these Alzheimer's patients, they're 80 years old. We do the procedures on them. They go home within 2 hours. We open the blood-brain barrier. It's still open. They go home. And so it's a whole new era. We need to do more research. But if we can link it to antibodies or glioblastoma or some of these targeted delivery, you put the delivery anywhere. And I didn't show the slide for time, but many research done with pontine gliomas. You can deliver agents, chemotherapy to the pons, to the midbrain, to the hippocampus. You can deliver to open the blood-brain barrier across peel surfaces, across ventricles, cortices, everywhere in the brain, accumbens. So really, I think, in my opinion, the blood-brain barrier opening linked to a targeted therapeutics is going to change the neurosurgery, in my opinion. Reese, what do you think? You're an expert.
Dr. Reese, please.
Yeah, I think the future is, I agree with you. The real expansive future for focused ultrasound is the ability to deliver strategically biologic agents into volumes that you want to get, that were previously inaccessible. And so that opens up a whole domain of non-invasive interventions. I think in the short term, over the next 5 to 10 years, it's, I mean, I'm just focusing on lesioning, but you know, I think it's a great tool for lesioning. It's still a tool. I mean, the most effective, cost-effective is a radiofrequency electrode with a reusable electrode with a reusable stereotactic frame. It's fantastic. It's cheap, and I mean, it's relatively inexpensive, and it's reusable. The focused ultrasound does the same thing. It's still surgery. I think of it as still surgery. It's just no touch surgery. And it's outpatient, and you don't have any of the standard risks of surgery, but you have the standard risks of making a lesion in a delicate location. But it certainly opened up surgery to a whole nother population. I think our average age that we've done is 77 years of age. And I have done 90, you know, I've got 50 patients that are 80 and older. I've had several that are 90 and older that we're doing surgery on. So I'm not sure I'd feel comfortable doing an open radiofrequency thalamotomy or in those kind of patients. But so it's a very good, it's just a tool. It's a neurosurgical tool. It's pretty remarkable that as a stereotactic surgeon, we can see the lesion being made as we make it. I mean, it's very gratifying. But it's just another way of doing an old operation. But I think the potential is in what Dr. Rezai was talking about. The real potential a decade from now and 2 decades from now is we have to understand this tool better and what it can do to open up blood-brain barrier. And there's a whole field of neuromodulation, directed focused neuromodulation that is just developing. So it lots to be learned. A lot to be learned.
Dr. Lara Newton, you should buy it in Brazil. I know you have money. You work in São Paulo. São Paulo is a millionaire neurosurgeon.
I think a country like Brazil, we have to think more about reward network. I think would be very, more important in changing health, public health, than focused ultrasound. Here I'm talking about addiction. I'm talking obesity in a middle income country. Like here in São Paulo, we have a neighborhood that is called Crackland. You have Disneyland, we have Crackland. It's a whole neighborhood with people with cocaine dependence. So I think that it's for us would be much more useful to have some interference with with addiction. And another problem with middle income countries is obesity. We're beginning to be a very fat country, like the US, where is now. So that's a question for Dr. Ali. What does he think about obesity and nuclear accumbens for obesity? That's what I think would be very good difference in Brazil.
We did a study with the FDA on subjects for obesity and deep brain stimulation, and we stopped the study because obesity is very, very complex. It was people who failed bariatric surgery and very severe obesity. We did 3 subjects, FDA trial. All 3 lost 100 pounds more, but severe psychosocial behavioral issues. 1 subject committed suicide, was not linked to DBS, determined by the FDA and us, but very complex. And 1 subject had removal for complex reasons. And so we said it's not feasible. We published it as editorial in Neurosurgery. This is not feasible. But I think the behavioral domain may be better with the elegant lesioning versus an open surgery and putting an implant and having to deal with the long-term manifestation implant. I think neuromodulation using this technology may be good to help people. And I do think that the big areas, like you said, addiction, obesity is type of addiction as well, but addiction, Alzheimer's, these are big public health things that neurosurgeons need to be involved more. And I believe potentially focused ultrasound, whether it's neuromodulation or BBB opening or lesioning, can have an impact potentially in the future. We're doing a study now with focused ultrasound with nucleus accumbens for severe opioid addicts, an FDA study. We did 2 patients where we increased cravings with the visual cues, showing them shooting heroin, and the craving scale went up. And then we gave ultrasound a dose to the accumbens to reduce the cravings. The results are interesting. FDA said, do first 2 if it's safe, now do the last 3. So now we're doing the last 3. But I think the neurosurgeons need to shift towards big public health issues as well. And that expands the domain for neurosurgeons, addiction and Alzheimer's, but we need technology. You cannot do open surgery, in my opinion. If you have 80-year-old lady with Alzheimer's, she's not going to want her head shaved, do surgery. So if you do shaveless and do ultrasound, maybe that's better, or link it up with antibodies. We got to do research. But I believe focused ultrasound, as Reese said, is a tool that makes it a more sophisticated tool for lesioning. But it's another tool with a BBB and neuromodulation application beyond lesioning that's going to dramatically, I think, open what neurosurgeons do. And it's not just functional. All neurosurgeons can do this because you can target the brain, open the BBB. So this opens up a whole new arena. I think the next 5 to 10 years are very exciting times for focused ultrasound. I didn't talk about neuromodulation. It's separate than BBB, separate than lesioning. You just send neuromodulation beams of ultrasound to rewire the brain temporarily. It's being used for movement disorders and pain and other areas, but we need to do more research. And you don't need an expensive system for that. You can use a homemade custom built system for that, like it's been done at UCLA for minimally conscious states and others. So good area for research. I hope I answered the question.
Yes.
Yeah. Dr. Henin Mora. Henin Mora is from Ecuador. He's the president of the chapter of neurosurgery, functional neurosurgery from Latin American neurosurgery. Dr. Henin, after a very exciting presentation of Dr. Ali Hazai, I was thinking, Dr. Al-Meftys, to leave the drill and the microscope back, put out, and buy this ultrasound. It will be better for us. Henin Mora, you feeling the same in Ecuador?
Hello, Professor Lee. Excellent presentation.
Thank you.
I have a question. When you choosing procedures for tremor, Parkinson, for example, would you choose DBS or ultrasound? What would you offer the patients?
Okay. So if it's a Parkinson's that has exclusively tremor symptoms, which is not very common, and they have disability from tremor, then I think ultrasound is a good option. But if they have other symptoms, rigidity, bradykinesia, and others, we still do DBS. We need more studies like the subthalamotomy study that Obeso showed in the England Journal, or the pallidotomy studies. If the results remain positive, then maybe we would just do ultrasound lesioning for those. So I would say right now it's only for those that have tremor dominant Parkinson's with no other major symptoms, and the tremor is a disabling symptom for that. Reese, is that the same? Well, what is your, okay, yeah. And patients are coming to us, like what happened with ultrasound, as Reese was saying, a lot of people come to us now in their 80s that would never come for DBS, and they're getting ultrasound because it's much easier and they go home. So that's opened up sort of a new age group for us that they're coming in. People that would have never come for, they're afraid of surgery, they're coming in for ultrasound from their essential tremor. So interesting times. But I love the lesioning, and Reese does it. You see on the screen, you see the thermometer, you see a lesion, and the patient is awake. It's really satisfying, and it's really cool innovation, and it's fantastic.
Alexandre, please go ahead. Alexandre Francisco, go ahead.
Thank you, Barbara. I have two questions. The first one is that, and please, Ali and Dr. Cosgrove, correct me if I'm wrong, the first use of focused ultrasound was for chronic pain. And Jean Monod in Switzerland did that, if I'm not wrong. So I would like to know your opinions, or if you have any personal experience still with patients with chronic pain using focused ultrasound, and what should be your expectation about it. And the second question concerns essential tremor. And we know that when you do DBS for essential tremor, there are some patients that may experience on the middle and long term some kind of accommodation. They may lose the control of tremor. So we don't know if essential tremor is progressive or if the brain is actually accommodating to the stimulation. And I know that one of the biggest experience with focused ultrasound is essential tremor. So I would like to know if you have some, not any formal study, but what's your impression about the middle and long-term follow-up of these patients with essential tremor, if they do better on the long run concerning control of the tremor than these patients that may develop resistance to DBS?
I mean, great question. I can comment on the 50 patients that I've been involved with, Vibor Krishna at Ohio State and now at WVU with our team here. Initially, we made lesions small. We were afraid, we did not know. And we've had an initial cohort, some recurrence. As we got more experience and got bolder and adjusted the lesion to be a little higher to begin with, and the tractography, stay away from the corticospinal tract, we made bigger lesions, stack lesions, multiple lesions. So in the initial cohort, we had recurrences. I can only comment from our experience of almost 5 years. We've had 2 patients that have progression that required re-lesioning. So I don't know, the long-term studies are 4 to 5 years, 6 years still. They seem robust, but the lesions have to be bigger. The initial days were smaller lesions. So now we're making bigger lesions, and I think their recurrence is less. That's our opinion. Regarding the pain, I don't have experience with pain, but Jean Monod has good experience, and they did great results with pain in the intralaminar nuclei, central laminar nuclei.
Do you guys have any experience with, or would you think about focused ultrasound at the posterior subthalamic area for these refractory tremor patients? Do you think it would be safe to do 2 ultrasound lesioning for this specific population?
I think so. I mean, I don't have experience. Maybe Reese has more experience than I do with lesioning. Maybe Reese can comment.
Or maybe let's say that a patient has a DBS for VIM DBS for tremor, for essential tremor, and then the tremor recurs, and then maybe focused ultrasound may be used. I don't know if it's feasible to use focused ultrasound with an implanted lead. I think that maybe
it's tough because the MRI is 3 Tesla MRI, at least in our center. So you cannot do it with DBS with 3 Tesla and you bring him back in an image and make a lesion. It's not safe. So quite great question, but we have not been able to do with somebody's got a DBS. But we have reversed somebody's got a focused ultra on one side, do DBS on the other side. Maybe Reese can comment about the recurrence and all that, because his experience is very extensive.
Dr. Al-Meftys.
Reese.
No,
I'm here. I'm always here for you, Borba.
Yeah, you have some feelings. You know that you are different.
Yeah.
What do you think about this ultrasound?
Yeah.
Because the blood barrier break may change everything.
Yeah.
For GBM, for a lot of disease.
Yeah.
More than tremor.
Yeah.
We can treat GBM, drug delivery, that today is almost just impossible. What you are feeling? You know that
What am I?
you are Arabic man.
Professor Borba, there was an old commercial says when E.F. Hutton speak, people listen. And you got the best two experts up there talking. I will shut up and listen and learn. Because I'm an ignorant, but I could ask a layman a question on the line you brought. Okay. I first heard about the focus ultrasound from both the late Dr. Steiner and the late Dr. Frank Holles here, who were talking about it with a great excitement, more excitement than what you just heard. And I loved it. I thought this is the way it should develop. The reason being, you could do exactly what they're doing with radiosurgery without the danger of the radiation. So just imagine that all of those acoustics that being radiated today, they could be treated with a safe ultrasound, because the effect is the same thing, the principle of focus, stereotaxic, the same thing, the targeting is the same thing. You just took the poisonous radiation away and made the medicine more safe, which the ultrasound. So that's my question will be, where the future of this for that, for the 200,000 radiated people today with the gamma knife who could be treated better with the ultrasound. That's my inspirational question, if you want. Now, I do have a technical question. You know, cryothermotomy, stereotaxic thermotomy. It's a more precise target than what you have. It's a more controlled target than what we could do with ultrasound. It's a proven results life time improvement, and it's so cheap. A tank of a hydrogen, nitrogen, liquid nitrogen is pennies. Why will we replace something proven, better, more precise, and dirty cheap with something we're trying always?
The cryoprobe, Sam, is about 4.5 almost millimeters in diameter to shove it down into the brain. So it's like driving a truck down into the brain. It works pretty well once you get it down there, and you turn it up until the ball of ice causes a hemiparesis, and then you say, okay, stop, because that's how you knew you got close to the capsule. It's not the right way to do it anymore, unless you could get a very fine, and then it's just about like using a laser. The beauty of these are all, I mean, radio frequency is probably the most effective and efficient way to make an open stereotactic lesion. There's no better. It's very predictable and very, so this is different in the sense that it's incisionless, it's no touch surgery. But yeah, there's a whole bunch of reasons why you can't do skull-based lesions with focused ultrasound. There's still a fair number of limitations with it. I mean, we've only had it in our hands for really 5 years, but you can't do things near the skull base because of reflection back off the skull base. You have a limited volume with the high frequency in the center of the brain. It even makes pallidotomy sort of hard to do. I don't like using the focused ultrasound very much for pallidotomy. A radio frequency probe has the perfect trajectory to do a lesion in the pallidum. I mean, But having said all of that, it's just a wonderful tool. Maybe you can treat tumors in a different way by focusing very accurately some way to open up a blood-brain barrier that you could put in a neurotoxic agent for a tumor and limit it just to that area, rather than use radiation, which is damaging. So,
but you don't see it replacing the radiosurgery, the gamma knife or cyber knife or whatever.
no,
And the reason being the location with the response to the ultrasound or reflection.
yeah, and our limited treatment volume at the moment. I mean, it'll expand, but it's most of the energy gets blocked by the bone.
Right. The bone
And
is important.
The bone is the important thing, and so radiation doesn't care about bone.
Right.
Very much.
But there, in my opinion, there's no need to do thalamic gamma knife anymore. From my perspective, I think skull base, I agree with Reese, but I think higher up thalamic or other areas that are more in the midline, in the thalamic region, those are good for lesioning. But with the BBB opening, we can go anywhere.
You can use for AVM?
I don't know of any AVMs. I don't know, Reese, I haven't heard of any studies for AVMs. I don't know. It's a good question.
No.
And Reese,
Or cavernomas?
I haven't heard of it. It's a good question. I don't know. I want to ask Reese in response to Alex's question, what is your thoughts about recurrence and for the Parkinson's also? I mean, Alex asked a great question, or pain. What are your thoughts on that for the esteemed colleagues?
I have not used this focused ultrasound device for pain procedures or central-lateral thalamotomies, or it's not, and I can't use it for cingulotomy. I have done radiofrequency CL thalamotomies with, in neuropathic pain, just duplicating the same targeting. Seems to work okay. There's no perfect solution for these people with chronic pain. In terms of we've done about 200 patients now, focused ultrasound thalamotomies. We have, a handful of patients out at 4 and 5 years. We have some very nice, long, enduring responses. The bigger the lesion you make, the more enduring the response, the more complications. The smaller the lesion you make, no complications, but the tremor comes back. Yeah. I mean, we know this. So the key is to get perfect location. It's the Goldilocks principle. Not too big, not too small, just right, in just the right location. I think I'm still learning. But we have good sustained results in about 80% of our people. But they're even in this focused ultrasound, we have some people who 3, 4, 5 years out, everything's still good. Proximal postural tremor is easier to treat than intentional fine distal tremor. That's been my experience. I don't know, Ali, is that your experience too?
Exact same.
I mean, all my failures have just been in the fine intentional tremor.
Yep.
And I've done 4 people. I've gone back on 4 out of about 200 to try and get the good result again. Mixed results, I have to say. I think half good, half bad.
Sorry,
half no improvement.
Bilateral lesioning?
I have not. You have to understand, I did bilateral radiofrequency thalamotomies in my training, and I got scared. And so I'm just a little more cautious. So, Ali, you've been doing them. And I think part of it is that the targeting is so much better with this focused ultrasound. There's no brain shift because it's closed cranium.
Yep.
You see the lesion being made while you make it. There's no passage, down through the brain, through the frontal lobes, to get to your target with an instrument. I mean, I was trained by one of the great masters of functional neurosurgery, Dr. Bertrand, Gilles Bertrand, and he probably did 1,500 of these thalamotomies and about several hundred staged bilateral. He was always very cautious, and he taught me to be cautious in this, and I saw some bad results. So I was careful on this, but I think it's possible. And I think this trial will show that it's possible.
Yeah, the results in the trial so far, I think it's like 40 patients have been done recently. We've done 3, and so far we've been good results. We target a little higher than the other side because I'm worried about getting down for some gait. But so far, knock on wood, so good. And I think the overall results seem good across the centers.
Yeah, that's what I've heard.
Yeah, but and I think in about six months to a year, it may be FDA approved. So I think bilateral will be an option, but you cannot do it at the same time. You have to wait. You cannot do it at the same time.
When
Ali and
when we operate on patients, they may be at an age when conditions are good. After years of DBS, conditions can be worse and reintervention can be dangerous. A patient with DBS in STN has had great results for years, but with a recent onset tremor, after several years of DBS refractory, would you recommend an ultrasound application? Or another case, with embolism, would you indicate application of ultrasound in GPI? Older patients is a option.
I mean, from my perspective, we cannot do if somebody has a DBS implant, you cannot do ultrasound focused lesioning because they have to be in an MRI environment for hours, for a couple of hours. So you cannot do that in the DBS. I don't have experience with hemibalism and this, but subthalamotomy has been done with focused ultrasound. And people in the 80s are routinely, we do focused ultrasound, but not with the DBS. Reese, I don't know your experience in this.
Yeah,
they are already operated. It's after DBS implant. After DBS implant, you need something to do. Ultrasound is an option or not?
No,
no,
yeah, you can't do it. No,
because they can't go into the 3T MR safely. Although some are and I think there'd be big limitations about blocking off areas. So I don't think it's possible.
Right.
You know any cases of skin burns due to the ultrasound procedure?
I've heard of them. I mean, not in our experience, but that's why the cooling of the head. The head is cooled with a 15 degrees water temperature. Every 3,000 joules, you have to wait up until there's an algorithm that cools the brain. So you cannot retreat until the brain is cooled. I mean, the scalp is cooled, right?
Yeah.
Sorry. Scalp,
sorry. We reported clear-cut changes in the marrow of the bone in patterns clearly related. And it gets harder and harder to do the lesioning after you've done it. So something changes when you're treating the patient with focused ultrasound. It gets harder and harder and harder to do in the same patient at the same sitting. You only get so many shots at this. And I think it has to do with some change in the bone.
Because a lot of the energy gets absorbed in the bone. The vast majority gets absorbed by the bone. That's why we do a skull density ratio assessment. A lot of technical details, but if you have a skull density is not optimal, you cannot do ultrasound. It's not good.
Okay.
Ali,
Well,
that was terrific, and thank you so much for doing for us. But
Pleasure.
Borba always asks the right question and the tougher question. Okay, so you cannot work yourself around it. You have to face it. We in neurosurgery, so many things comes and goes. The laser was gonna evaporate all the brain tumor. We don't need any knife or anything. The vaccine is gonna treat all the glioblastoma. You just need to inject the vaccine. all of those innovations are welcome, but they certainly, the search for their application expanded beyond the reasonable or the success, and that finally it will be determined where it's really good. So, Borba question, where do you think this new great innovation is gonna be truly effective and flourish out of all of this
So
wide range applications? That's
I
his
I really
question.
believe,
That's not mine. That's
yeah,
his.
yeah.
Mine was in broken English. Yours is in English.
But the blood-brain barrier has been a constant issue for all neurosurgeons and all treatment deliveries. I showed that one slide that showed what size molecules can cross. And I agree with you. We got to study this because we've had many things in neurosurgery that's come by, and especially for glioblastomas, which is a very challenging condition, as you all know very well. But I think that the way we're doing this is very careful design studies. We have neurologists engaged, physicists engaged, many people engaged, very high quality journal publications. And I think that, in my opinion, the BBB opening where the neurosurgeons can now deliver therapeutic agents with the evolution of therapies, antibody therapy, gene therapy, everything can be given now potentially with research using ultrasound in an MRI without cutting the skin and deliver it to anywhere in the brain, from the pons to midbrain to the hippocampus, hypothalamus, all have been targeted. So the entire brain is open for targeting potentially and therapeutic delivery without cutting the skin, with precision of a millimeter, without shaving the head, and without a frame in a year from now. With careful studies, we got to get the studies very early on. So you're correct, but the BBB opening has been a big issue for neurosurgeons for decades, and now we can open it reversibly and reproducibly and safely on demand.
Borba, do I have time for one final question?
Yes, go ahead, please.
We know that when we do functional procedures with radiosurgery, we may have some potentially life-threatening delayed side effects with radiosurgery. And I'm following what Dr. Al-Meftys says. Do you observe these delayed side effects with focused ultrasounds, or they are immediate side effects that wane on with time?
In my experience, lesioning is immediate. They get some swelling that may last, but you see some maybe worsening of some of the symptoms, but it gets better. So that's the beauty of it. The lesion is right there. You see it on the screen. You do a temporary testing. So in our experience, you see it very shortly if you see problems afterwards. We have not seen delayed effects. Reese, I don't know what your thoughts are.
We've seen no delayed side effects whatsoever. We've seen the side effects are acute. I mean, maximal about 72 hours afterwards, like anything. And then we've even seen improvement in a delayed fashion. The one thing that I thought wasn't going to get better was taste. Some people have an alteration of taste in about 3 to 4% of people. And I said, once they got that, it was never going to get better. But even those people, it tends to get better, but may take 12 months, even 18 months. So we have people who, have improved. So no delayed side effects. It's not like radiosurgery where it looks like you're a hero because nothing happens acutely. The side effects occur 12 to 18 months down the road, and then you can say it's not my fault, right?
Reese, why the test? If you're shooting a target up in the thalamus, the test affected in which way for all of this permanent or long lasting? What's the pathophysiology of this?
It's a more media. I'm not an expert on the taste, and you would think that a unilateral lesion wouldn't alter taste. At least I wouldn't think so, because it's it's a more medial nucleus beside VPM, and that's where taste is, at least that's my understanding. My understanding is not very good on taste, but I would have thought that a unilateral lesion wouldn't interfere with taste, but it does if it's more medial and posterior. That's
Yeah.
Is that something we see with radio frequency or other method of ablation?
I never saw it with radio frequency.
Yeah. And it's a metallic taste, Reese.
Yeah.
Our patients, it's I don't know, it's peculiar. It's metallic, and you're right, it's unilateral. So I agree with you. It's posterior, medial, somewhere in the sensory nucleus. I don't know. It's very interesting. It's a metallic taste, they say, but it does go away. You're right. Yeah. Not in all, but I'm encouraged by you saying 12, 24 months, because we have a couple of patients who are like, I still have the taste. They're very happy, but they feel the metallic or a little sensory loss, taste loss.
Sometimes it doesn't go away, but we've had others that it was there and it has gone away by 1 year or even 2 years.
Yeah. So we're targeting a little more anterior to get away from that maybe sensory nucleus. I don't know.
It's not predictable in my book.
Yeah.
Yet. I haven't figured it out yet.
Okay, you have now 2 hours online. Dr. Al-Meftys, in almost 1.5 years, more than that, you are doing webinar every week or every 15 days. I don't remember one webinar you have more information for the future real neurosurgeon than in this webinar. I think you didn't learn too much like this webinar. All right, to thank Professor Rezai, Professor Crossgrove. Doctor, if you leave for Dr. Al-Meftys, will be more 3 hours here talking, asking questions. Dr. Al-Meftys never been so excited. You see, in half of time he's sleeping, his camera is off. Now he's on all the time. Thank you, Professor Rezai. No, I think you are very excited. We as a neurosurgeon, I think your future is on. You have more and more come in the next years. Let's see, Dr. Al-Meftys. It will be one more tool, or it will be the tool. That's to be the difference.
Look forward to seeing you all soon in person. We're looking forward to seeing everybody in person. It's been too long.
Okay. And after that, you show something about Dr. Al-Meftys when he was resident in Morgantown. Maybe he has some bad things to tell to everyone. Okay, thank you very much.
Thank you, Professor Al-Meftys. Thank you.
Bye-bye, thank you. Thank you, Professor Al-Meftys.
Thank you, sir. Thank you.
Thank you.